everybody, it's Ed, and I want to tell you about the Monday Afternoon Journal Club. It's a new thing we've been doing on the Overrun here on YouTube, and we're really excited about it. We've gotten a lot of really good feedback for it. What we're doing is we're taking new journal articles that have been published within the past year, 6 months, 3 months, and sometimes even the past couple weeks, and updating you about new EMS information, whether it's clinical care, response times, operations, all of those things. We're bringing you the newest EMS data. So subscribe to the Overrun on YouTube and check out the Monday Afternoon Journal Club most Monday afternoons. Now back to the show. Hey everybody, welcome back to the Overrun podcast. My name is Ed Bowder.
Dan Schwester.
I'm Mike DiFilippo.
And Dr. DiFilippo has come around to publish a paper yesterday. As we're recording this, Mike DiFilippo, our medical director, has published a paper in Air Medical Journal talking about double sequential external defibrillation for out-of-hospital cardiac arrest. This is something that we've discussed previously, and I'm going to bring the paper up on the screen here just so our viewers can see it. So he wrote this in collaboration with some of our friends out in St. Louis as well. Mike, this is really a literature review of a couple different papers on dual sequential defibrillation. And really, we wanted to have you on just to talk about what your findings were and talk about this paper, because it feels like, at least in the common conversation, dual sequential has not fallen out of favor, but it's not like the big conversation point anymore, right? There's a lot that's come out about whole blood and all this other stuff, but the dual sequential stuff, I think, was really, really big news a couple of years ago. And if you read the literature, it's still really big news, but it's not as popular in, popular media as it used to be.
Yeah, it's like right. It's like the fan favorite, but never really got any commercial success. And I don't know. It's a thing.
Well, I guess I'm a cultist follower, kind of like the Big Lebowski. That's my V-fib is my Big Lebowski.
All right.
Where's the cardio version, Lebowski?
Yeah. Yeah. Oh, sorry. Go ahead, Dan.
No, but the funny thing is that we were doing this like 10 years ago. If you remember back in the day, this was a thing. And I remember our medical director, Dr. Merlin, being really big on this and pushing it, and it kind of slid by the wayside. And now we're seeing a resurgence in this idea. And we'll talk about the DOZ-VF trial and some of the other literature that you looked into. But it's an idea that's been floating around. And is it ready for prime time?
100% yes, ready for prime time. And I would say if your agency is not doing dual sequential defibrillation or dual sequential external defibrillation for refractory cardiac arrest, or is at least not talking about it, you're very behind the times.
Cool. Thanks for watching the Overrun podcast. That's the end of the show. We'll talk to you all next time.
Oh, that was quick.
I'm very, like I said, so I'm very vested in.
Does it work? Yep. All right.
Fine. But yeah, I mean, V-fibs has been just a personal interest topic for me, and I talk about it pretty much to anybody who will listen to it. But I think historically, at least anecdotally from our experience as paramedics in the New Jersey area, I think we were very lucky to work in a very progressive system at that time. Not that it isn't now, but we were doing hands-on defibrillation before there was mechanical CPR devices. We were doing the dual external. We had pre-hospital physicians who were out there working with us. So I think the system itself just lent to innovative ideas in the pre-hospital environment. Now I would say what we're seeing is that we're having the science and evidence-based literature really to sort of support these techniques. And I think that's really what I like to say with these. I mean, VF is its own distinct entity within cardiac arrest. And I think really what I'm getting at is refractory VFib, not necessarily a recurrent VFib. And we'll go into that as we talk about this literature review. But refractory VFib is its own distinct clinical entity that needs to be treated very differently than any other subtype of cardiac arrest. And I think it sort of is a change in the frame of reference and the mental schema you have in going into cardiac arrest that sort of, I feel like the way ACLS and paramedic school and even, sort of emergency medicine training and a lot of acute care training, intensive care, internal medicine, hospitalist training, really sort of tries to bundle cardiac arrest under just, it's a cardiac arrest. You give your epinephrine every 3 to 5 minutes, you get IV access. If there is VFib or VTAC, you're going to give amio, and you have your small little branch points, but generally every cardiac arrest is sort of run the same. And I would say that's really not bearing out to be true, as we're doing a lot more research into resuscitation science around cardiac arrest. And I think really why we are seeing this emerge with the DOZ-VF trial and a lot of these papers and the research really talking about ECMO and really other interventions, particularly focusing around V-fib, is that we are sort of now understanding that there's different sort of, trying to think of the word, I can't remember it right now, you just have different flavors, so to speak. Like not every cardiac arrest is the same. And my big point in my education, especially around cardiac arrest and resuscitation, which is my wheelhouse, is that I really urge people to think when you have a V-fib arrest, you need to break out of that mental schema of regular cardiac arrest, ACLS protocol stuff, because we're learning that is really a different etiology and a different way to run these arrests. Like, not
so it's really it's more like seeing cardiac arrest as its own disease process and not so much seeing it as a protocolized type of injury.
Correct. Yeah, I think, a better way of sort of approaching this from a similar sort of mental framework would be when you're on scene of a respiratory distress patient, you're not going, I'm on scene of a COPD exacerbation, and I'm only going to treat this as a COPD exacerbation. You're building a differential for that undifferentiated respiratory distress where you're like, okay, I'm going in and I'm thinking of all these different things. Is this an MI that's causing shortness of breath? Is this a PE? Is this CHF exacerbation?
So it's kind of like changing the almost flipping the ACLS algorithm on its head, right? Because toward the end of cardiac arrest, that's when we talk about like H's and T's, reversible causes, and it's almost like that's something that you should be considering in the beginning.
100%.
Like while establishing an airway, okay, this cardiac arrest the cardiac arrest in a 35-year-old is different than the cardiac arrest in an 80-year-old.
Yeah, 100%. And I think, I think just you hit the nail on the head here perfectly. I think when you're initiating resuscitation, there are things that we know every cardiac arrest is going to get. They're going to get CPR. They're going to get some sort of airway management. They're going to get some sort of either IV or IO access. And that I would say is probably the baseline framework where it should stop, that things are similar. I would even argue that not even just V-fib, but your narrow complex PEA versus wide complex PEA. And really, I think cardiac arrest is one of those things in medicine that the history is actually really crucial as to the steps that preceded the patient going into cardiac arrest. A lot of things now in medicine with the advent of science, lab work, CT imaging, X-ray imaging, the story, do you need it? Yes, obviously, to help guide your workup a little bit, but really you're getting a lot of objective data back. Cardiac arrest is really one of those things where we don't get a lot of objective data and we're going based off history, or does what we see like very, very minimally. We have very minimal objective data. We have a cardiac monitor. Sometimes
I maintain that we haven't elucidated enough data on the PR administration of tobacco smoke. I feel like that we haven't done enough trials on it. It was abandoned way too early in the 1920s.
Yeah.
And I think perhaps we should go back to analyze the old ways.
Nicotine as the new prepper.
But it makes total sense if you think of it from the side of the heart stopped. There's a lot of different ways a heart can stop and stop producing cardiac output. We have to look at the whys so that we understand how to treat it. You can't just randomly, empirically throw things at the wall, expect them all to stick and be successful on a regular basis. Ed, every show we've ever done on cardiac arrest, you're like, we have no idea what the fuck we're doing.
We have no idea what we're doing. Yeah, and that's pretty much right. And I think that again, a lot of that has to do with protocolizing how cardiac arrest works. It's one of the few things that we have a sort of a one approach fits all type of thing. And how many patients do paramedics go to every year where they do the 3 rounds in a cloud of dust treatment because that's what we do. So that's why we want to get into asystolic arrest is its own thing, right? That's its own field. It has its own survivability, its own mortality. But here, as long as we have people that have some kind of electrical activity in their heart, we do have the chance to resuscitate them. So, Mike, I want you to go through some of the definitions that we talked about earlier, and then we want to get into what you found in your literature review, and then also some operational concerns of how to actually improve outcomes in cardiac arrest. So, go through some of those definitions that you were talking about earlier. And then let's clear up different types of V-fib, and then let's get into what the literature actually suggests for DSEDs.
Yeah, certainly. So, that's actually one of the big issues within the literature right now is there is no standard definition of what a lot of these things are. That's starting to change, especially with the work by Chesky's. He's sort of become a big name in the field. And And his definitions that he's used in his studies have sort of worked their way out, I would say, into at least the emergency medicine and intensive care literature whenever you're talking to somebody about these things. So we sort of use those definitions in this literature review. So what is refractory VFib? It's any VFib that persists after 3 standard defibrillation shocks. And by standard defibrillation shocks, we mean either anterior-posterior defibrillation shocks, whether that's done with a life pack, a Zoll, or just like a standard public available AED, doesn't necessarily matter. DSED, double sequential external defibrillation, is also misnomered by double sequence or double simultaneous external defibrillation. It's really one the studies that are looking at it is not the simultaneous defibrillation, which actually, looking back, that's what we were doing in the field as paramedics in New Jersey in the late 2000s. But what the literature is looking at, what has been successful, is this dual sequential. So simultaneous, obviously, as fast as possible, you're trying to simultaneously press those buttons to deliver a simultaneous shock. Dual sequential is rapid succession. So you're defibrillating on defibrillator number 1, and then very rapidly thereafter, you're defibrillating on defibrillator number 2. Looking at some studies, again, not present in this literature review, but just some other studies and lectures I've given, the double sequential is generally within about less than a second. It's pretty rapid, and the faster you're able to do it, the better generally ROSC rates are and V-fib termination rates are. Again, not necessarily studied in this paper, but just in other literature. So that's just sort of breaking down DSED, and very specifically within this literature review, we're referring to double sequential, not double simultaneous defib. And really the thought process behind this is, as we sort of alluded to, you're leveraging increased shock energy, so increased joules. This is after your 3 standard defibrillation attempts. And you're also leveraging increased myocardial coverage by adding a second vector in there. So instead of just having either your anterior-anterior or your anterior-posterior, you're now adding in that second vector of electricity to try and cover as much myocardium as you can from the external defibrillation. And then just
I think just real quick, the vector change, just to get into that and how important that actually is, because again, the placement of pads, specifically anterior-anterior, was based upon generalized anatomy. And because everyone has their own little turn to the heart that actually sits like in the mediastinum itself, there's not a one approach for everybody patient, or one approach for every patient kind of thing. So if you have someone that has an axis deviation, if you're trying to hit that focus to actually restart their heart, it may be in a different place than your standard placement. That's where vector change comes in. It's all in how the heart actually lays in the patient, which is information we don't have going into them.
Right. And I think also, again, another branch point we can go into why I think ultrasound is a really important tool for pre-hospital clinicians to have, to really take a look. I mean, obviously you don't have patients with dextrocardia where the heart's on the opposite side all the time, but they are out there.
But hey, it's out there. Yeah.
Yeah. And then lastly, the sort of last definition to cover is the difference between recurrent versus refractory VFib. Refractory VFib is VFib that just does not change. So you get no rhythm change. It is just staying in VFib the entire time. Recurrent VFib is when there are short breaks or long breaks, really any break in VFib. Generally, the literature says VFib with a break of at least 5 seconds. So go VFib, short break into asystole, and then back into VFib. So that's just really the 2 major definitions to be aware of. And we'll break down the literature and how that works as well as we go through these studies that we looked at.
Cool. So what we have here is, and again, we're kind of going to go through a bit of what you looked at here. So your first one here is the alternate defibrillation strategies on shock, refractory, and recurrent VF. This is the secondary analysis of the DOZ-VF cluster from Resuscitation in 2024. We're going to put this paper up and we're going to link it and all that stuff, but give us your big findings here from these papers, because I know there's a lot of overlap in the stuff that Chesky's did, but give us like some of the bigger take-home points.
Yeah, so I'll just walk through the 3 general papers we reviewed. So the first one, obviously, the DOZ-VF trial, which came out in 2022. This looked at, in Canadian EMS systems, whether or not vector change defibrillation versus dual sequential external defibrillation versus standard defibrillation had any change in survivability, termination of VFib, and neurointact outcomes. So again, standard defibrillation, like we discussed, your regular degular defib that we're all used to from BLS CPR. Your vector change defibrillation.
Regular degular is a clinical term, by the way. It's recognized.
Yeah.
You have to be board certified to use that.
Yeah. That's the problem with why I shouldn't have been allowed to go to medical school. They let the wrong one in. Vector change being, as Ed discussed earlier, changing the vector, so physically changing the pad placement to try to change the electricity delivery in the myocardium, you're shocking. And then double sequential is what we talked about earlier, where you have two external pads placed from two different defibrillators. Right. So they enrolled about 405 patients in this study, all who exhibited refractory VFib. And again, refractory VFib meaning that 3 standard defibrillation attempts and the patient was still in VFib. It did not break down recurrent versus refractory VFib in this study. And what they found was survival rates were higher in both the vector change and double sequential external defibrillation group compared to standard, but the statistically significant neurologically intact survival was only found really in the double sequential external defibrillation. And to really put it into like good terms, for the patients that had double sequential external defibrillation, about a third of them had a neurointact survival. The patients that were in vector change or standard defibrillation, only about a tenth of them had neurointact survival.
Interesting.
So it's quite a significant change. And me, as someone who identifies as a cardiac arrest researcher, VFib enthusiast, whatever you want to call me, that when I read that, I was like, holy shit, this is practice changing 1 billion%. I don't care if it's one study like that. That is just, it's 400 patients. It's a pre-hospital system. But it's just one of those things that I feel like when you're looking at literature, obviously there's lots of things. Does this apply to my system? Was it a similar study that was done? Similar patient population? I think Canada's pretty similar. It was only 400 patients. It was only one study. Sure, there's a lot of these things. But I think the impact on survival, and this really isn't the harm here, is really non-existent. And that's really what I look at as a physician. What's the harm to doing this in someone who's already dead, in someone who's dead and has a refractory ventricular dysfunction? Like, what else are you going to, especially in a pre-hospital environment?
That's part of the debate, right? Is, there's, and we've talked about cardiac arrest data before where, you'll have bystanders who are unwilling to do CPR because they're afraid they're going to hurt the patient. I reject the notion that we can cause further damage in cardiac arrest. You know what I mean? Like that's what further can we actually do?
I think that makes sense.
Yeah. And I think in that type of setting, we have to be willing to make these kinds of changes. And of course, we have talked about, like, if you've seen one system, you've seen one system. What I liked about the 405 patients is that it's significant enough that if you can't extrapolate it into urban settings, you can probably extrapolate it into suburban settings, which is where most of our patients live anyway. Right. So seeing that kind of thing, like, all right, we think about our response models where, in New Jersey, we're in a state where typically BLS is on scene before ALS. So you would want to put this out saying, like, if you're going to do BLS, get out there. This is another thing confirming, early CPR, early defibrillation. If you don't have a good shock, you can change your vector and just kind of move on from there. So I did like this study. I do like the sample size. Keep going, Mike.
Yeah, so that was sort of the foundational study that I would say, when you're talking about resuscitation literature, the last few years have been really exciting between ECMO papers, and this was one of those studies that everybody in the resuscitation world was like, whoa, we got to look into this more. This is definitely has potential to be truly practice changing. So then 2024, last year, Cheskis did a secondary analysis, again, published in Resuscitation. And so what they did was the same data from that first study, the DOZ-VF trial, which was a pragmatic trial, meaning seeing how this works and using existing infrastructure, all those sorts of things. The secondary analysis was really to further delineate outcomes between DFib methods for those who were in recurrent versus refractory VFib, looking at the DFib data itself. So again, just to remind everybody, recurrent VF was defined as the absence of VF for at least 5 seconds. So going VF into an asystole and back into VF or any other rhythm, whereas refractory VF was defined as just not changing at all. True shock refractory, 3 DFibs, but current VFib the entire time. So the primary outcomes were all the same as the first study. They were looking at survivability, termination, and secondary outcomes were all the same. Termination of VFib, neurointact survival, and all that. So what they found was overall, those who received double sequential external had better outcomes than standard or vector change DFib, most notably for patients in true refractory, not recurrent VFib. So what does that mean? So vector change defibrillation was not found to be significantly better in survival to hospital discharge rates. However, the significant outcomes were really seen in the double sequential. So that's really why a vector change and double sequential, again, I'm someone who lives and breathes this stuff, for the last 2-3 years has been talking about both, either do vector change or double sequential. Recently, I would say within the last year, again, really since this study came out, a lot of the people on the cutting edge of this stuff within VFib research have been saying, okay, double sequential really seems to be where the meat and potatoes is for this true refractory, shock refractory VFib. Again, although the second study that we're discussing right now calls into question the utility of vector change defib, meaning that this secondary analysis really showed that vector change wasn't as great as we thought it was from that first study. I still think, and again, we wrote in our paper that this strategy is still superior to standard defib when you don't either have two defibrillators available or for whatever reason, you only have one set of pads. I still think logically it makes sense to do vector change because, again, what's that like old saying, like trying the same thing, expecting a different
the
outcome?
definition of insanity is doing the same thing over and over again, right?
Yeah, and
And
I think
I think that does make, because again, when we were talking about even doing dual sequential, I think the argument can be made that, instead of having the mass of energy that goes through the myocardium itself, it could be just that it's the second set of pads at a different vector actually is what caused the change, right?
100%.
I think it's a semantic difference, right? I don't really care which set of pads causes the effective change, right? But it's actually the act of removing the pads and putting them in a different location versus just having the two different sets.
There's also a little bit of physics here, right? We want the way defibrillation works, Mike, help me out, is you have to get a critical mass of myocytes to depolarize. So we have to get a certain number of them to terminate the rhythm. What vector change is doing is it's allowing you, and double sequential is allowing you to do, is to touch more the myocardium with that electricity so that those cells can depolarize. The other thing I want to kind of have you kind of comment on too is something that I got from the DOZ-VF trial and from Dr. Chesky's talks was impedance actually matters, that the resistance of getting through the chest really matters, and placement of those pads is important. And he even talks about putting pressure on the pads while defibrillating in some instances, which I think is interesting because we might be going back to paddles. Who knows? But it just seems to me like, it's really interesting how everything circles back. So
there's somewhere there's ghosts of medics from the 90s holding down pads, be like, I told you all this work.
Yeah, so I think you hit on a couple of very key points that I just want to circle back on. So I think impedance is a really interesting perspective on it. And I do agree with, I think a little bit of pressure on the pads because, again, talking about the physics of the things, and for our listeners, don't lose us yet. I promise I'll make it easy. Electrical resistance, you have a lot of different things in your body, not to, state an obvious thing, but you have bone, you have skin, you have blood in there, you have hollow and solid organs. And, electrical resistance is affected by all of those things. Electricity doesn't really run well.
Even just adipose tissue.
Right. 100%.
Right? We talk all the time of all of these trials being done on
all different densities, 70, all different moisture contents, all different, come on.
Yeah, that should be.
If all data is driven from a 70 kilogram white male, then what are we doing? If most people weigh over 100 kilograms.
Or your dehydrated grandma from the nursing home who doesn't have enough water in her body.
Exactly. Yeah.
But that's.
Hey, we just saw her 20 minutes ago. She was fine.
Yeah, she's fine.
It's fine. And this is how she looks now. Why is she frozen like that?
She's a full coat. It's fine.
Acute onset rigor mortis.
Yeah. Quick side note. I always love the pictures from the nursing home packet where they're already just like this in their profile pic.
Yeah.
And it's like, okay, I know their baseline mental status at this point.
Mm-hmm. Yeah, they're fine.
But yeah, I think Danny hit a great thing with the physics there. That's certainly one of the things. Again, and I don't know if this has actually been explicitly studied in the literature or not, but when you're doing anterior, you're putting, really over the clavicle, we're told here. You have to go through sternum, and then you have breastbone over here. Anterior-posterior, obviously you have your sternum, or really you shouldn't be putting it over the sternum, but you should be putting it over really left lower sternal border where the heart, the right ventricle really is sitting most anteriorly. And your back, obviously, you put it a little lateral out from the spine by the scapula, and you sort of try to hit those tissue windows. That's really when I'm placing pads, what I'm thinking about. I want to make sure the center of those pads where that electricity is going to be going through is really not near major bony structures, so I get good electrical delivery. Again, because the physics of it, bone is not a great conductor of electricity. Your fluid-filled tissues, your organs, the heart, those are really good ones. And again, Danny, to talk about the physics of it, like I said earlier, the double sequential, the meat and potatoes of it is not just the increased vector, or not just the increased electrical coverage, right? You're leveraging obviously increased electrical coverage by the dual sequential. So 360 times 2, that's what, 720 joules you're sending in there. You're also increasing your myocardial coverage by getting that. So you're increasing the amount of myocardium that you can try to get back into synchronized electrical activity. And you're also increasing the amount of electricity that you're going through and hopefully reducing the resistance and impedance of that electrical charge going through when you do that defibrillation.
And that's the other thing, is that electricity doesn't travel necessarily in a straight line through a human body, right? And you can see if any people have been hit by lightning, they have like all the injury patterns like that. So you have energy that's going to disperse as it's actually being delivered as well. So when Mike is talking about the actual myocardial coverage, you can think of it almost as like that diagram, right? Where we looked at like 12 leads, right?
Yeah.
I forget the name of the diagram, Mike. You can help me out with that. But
Actually, let me pull it up for you guys.
So, but that's one of the things that we want to talk about, is actually getting more coverage of the heart with a higher percentage that will actually get some kind of conversion.
Yeah.
So let's get into the logistics of this, Mike, because one of the hardest parts in the field is, getting that first AP placement of the pads in a cardiac arrest, because most places have an automated CPR device, whether it's, a band-driven device, whether it's a piston-driven device. So talk to us about how to set up for that. Is it one of those conversations where, like in the truck going to a call for a cardiac arrest, a lot of times we'll discuss, all right, I've got the airway, you've got the meds. Should we be changing our conversation and our flow to, all right, we get on scene first, this is how we'll position the patient. Like, how do we better prepare ourselves for success?
Yeah. So actually, really glad you brought that up, because I think that hits on another large topic when we're talking about resuscitation science. And that is, you cannot overlook the importance of systems or bundles of care and how it relates to all of these things. If you have poor communication with your teammates, if you have poorly trained clinicians, if you have people that don't know what they're doing or don't know how to work well together, you can dual sequential external defib somebody all day, but it's likely that patient's probably going to have a poor outcome because everything else is not working cohesively. So that being said, I think it's really important always, especially with high acuity calls, it could be a cardiac arrest, it could be a major trauma, whatever, to debrief ahead of time with your partner or whatever crew is around you while you're en route to that call. And that can even be done over the radio, by personal phone or whatever. It's not uncommon for me as a physician, especially where I work now. I have, fairly long response times, sometimes over an hour. It's not uncommon that I'll talk to a provider on scene and we'll come up with a game plan while I'm en route. That way we're already on the same mental framework. So again, to get back to the defibrillation related stuff, I think it's really important to discuss going into a cardiac arrest. And I would really have your feelers up for younger patients. And what I mean by younger patients is, the refractory V-fib demographic. You generally see two big buckets. It's younger folks, and generally like 50 and younger, with congenital disease or some sorts of, QT prolongation disorder that may already have existing defibrillators implanted or all that other sort of stuff. That's your bucket one of who gets refractory V-fib. And your bucket two is the older folks, or just unlucky folks who may be younger, who have had significant cardiovascular disease, multiple MIs and all this other stuff, who at baseline have irritated myocardium that go into V-fib. So those would be the feelers up, I would say, going to the call to keep an ear out for. And obviously, if you hear any defibs prior to arrival, you should definitely be having the discussion of, okay, I think we should do this defibrillator pad placement. I personally, Mike DiFilippo as a physician, advocate for 100% anterior-posterior pad placement as the initial pad placement for all cardiac arrests or cardioversions that you're doing. And the reason for that is that gets you the best coverage. I shared that image with you guys just to give sort of, I gave a CT cut to show where the pads sort of go. Your anterior-posterior gets you the best myocardial coverage of the key structures when you're trying to defibrillate. So I argue the initial pad placement, the discussion should always be had amongst your agencies, your crews. Whenever you're going to a cardiac arrest, AP should always be first. And the reason for that too is, let's say you do use an automated CPR device, doesn't matter if it's a circumferential or piston driven. Once you get that patient locked in, it is a pain in the ass to get them out, to remaneuver something or whatever, and you get quite significant handoff chest time. So by already doing the anterior posterior, you don't have to unlock them from the system. And if you're in a situation where you have that circumferential or piston mechanical CPR device, you recognize it's a true refractory V-fib case, then all you're doing is putting anterior pads on. You don't have to take the patient out. You don't have to lift them up. You're just adding on the anterior pads. So I think, logistically and operationally, that's why you should go into 100% every cardiac arrest, anterior-posterior pad placement as the initial pad placement, have a second set of pads available just in case that patient is in refractory VF. And if they are, even with mechanical CPR device, doesn't matter if it's circumferential or piston driven, you can just do anterior pad placement fairly quickly. If it's a band device, the band is actually pretty easy to take off and on again during a quick pulse check to put those pads on. And again, that's why one thing that we have to tout our system out here that we do very well is a lot of the EMS agencies out here, again, the systems of care is very important. Anytime prior to a pulse check, we're doing quite a few things. We have the designated person who's going to be checking the pulse. We auto-charged the life pack to 360 joules before the pulse check, just in case it is an underlying ventricular arrhythmia. And then we do our pulse check. And we have those things, 99 times out of 100, we're dropping the charge. 99 times out of 100, you're usually not feeling a pulse, but you have everything in place ready to go. And similarly, I would argue if it is someone that you're concerned is in refractory VFib, you have an additional person, if available, ready to just slap pads on. That way, the whole thing, and I'm telling you, I've seen it done, can be done in less than 10 seconds to maintain your handoff chest time as really, really low.
And Danny, this is something we've talked about previously, but this comes down to, training, practice, and crew resource management, where, having that conversation leading up to the arrest or leading up to your scene arrival is essentially, getting everything done in the first 2-3 minutes can set you up for success over the next 20 to 25 minutes. I think we talked about this previously where, going on to a job, going on to a call, you have to kind of have an idea of who's going where and who's doing what. So if you're coming up on a scene, walk through the actual conversation you have saying, all right, I'm going to do this. You're going to do this. We've gotten the update that there's been defibrillations. So how do you change your approach, coming up to the scene?
Well, in the past, before this stuff came out, we were just putting the standard anterior, get pads on, confirm that we've got good CPR, get a rhythm check, see where we're at. This is going to change how I operate now, because if I'm going to a witnessed arrest, especially if I've got a defibrillation administered, my pads are going AP. So we're going to undo the life band or the piston. We're going to lift them up, slap the pads on, go back to CPR during the rhythm check. And then we're going to look at the rhythm and we're going to see if this is a shockable thing. If it's shockable, we're going to go ahead and just do it. Go ahead and administer the shock. And we can do that with the monitor. We can do it with AED. My first thing is now I'm not taking that police officer's AED off very quickly. I might keep them in the right place and put my pads AP. And now if I've got refractory VFib, I can analyze with the AED. I can time the shock with my manual defibrillator, and boom, I've got double sequential.
And just so we're clear, this isn't every cardiac arrest either. Like, we're not suggesting that you run in to set up AP placement on every cardiac arrest you go into. It's this specific subset of refractory VF patients. So it's not every arrest you go into. It's just a lot of times, especially in a 2-tier system like ours, you get a call. All right, 2 shocks have been delivered. So you already kind of have an idea that you're going to be doing more. Just to clear that up, because I don't want people thinking that we're saying, we're going to go balls to the wall on non-viable cardiac arrests.
The situation you gave me was, this is a witnessed arrest. This is a collapse in a public place. We've got an AED on scene. We've got a police officer, somebody doing CPR. We've got a couple shocks administered before we walk in. That's going to change drastically how I'm going to look at this resuscitation, as opposed to a PEA or an asystole or an unwitnessed arrest. Very, very different. This is a chance for a clean save, as opposed to somebody who's not going to have a good outcome.
I would argue that every cardiac arrest, the initial pad placement should be anterior-posterior, with the rationale being that you never know. Obviously, you have high pretest probability of which patients may have VF based on their history or the story, but you never know which patient rhythm may degenerate or regenerate from a system to a VFib or a
Yeah, it's really, for me, it's really more of a cognitive offloading thing, because I don't want to have a conversation that says, all right, well, part of the problem has been protocolizing everything, and then say by protocol we should put AP placement on everybody, because I think that we walk into cardiac arrests that are pronouncements is really more what I'm saying. That's like
viable cardiac arrests.
Yeah, exactly. Like Danny was saying, like the fresh kill where this is something that is being worked, has been worked, and it still has electrical activity. This isn't
the person that hasn't been seen for an hour.
Right,
and
exactly.
Asystolic on arrival, but they're
this isn't
warm,
the acute rigor mortis patient.
No,
entitled CO2 of negative 40.
Yeah, exactly. Entitled of 4. Like, we know that. That's futile. We know
yeah.
it is. I'm talking about this is somebody who is viable, witnessed cardiac arrest. Look at your Opals criteria, everything that fits. This is a presenting VF rhythm or a VT, and it has been refractory. It has not stopped, or it's recurrent, meaning we got a break. They went back into VFib. We shocked them again. They did okay, and now they're back again. This is the time when we've got to start thinking, okay, this is where we need more myocardium depolarized. We need more to the ventricles. We need less impedance. We've got to start thinking that.
And Mike, just real quick before we get out of here, now that we're talking about, how we can save all these people, at what point with this new information do you consider termination?
Yeah, so that's a good point. Especially as a medical command physician now, when I get phone calls for cardiac arrest,
Right.
I think if you still, it depends. Let me say that. It depends
Sure,
on
yes.
if you are,
Mike isn't your medical director, and neither are we. You must follow all of your local protocols.
so it depends on your system. If you are in a urban area or even any area close to a hospital with ECMO capability, and the patient is a good ECMO candidate, and that's its own whole different podcast on its own, then I would argue if you're having still shock refractory VF on scene and you've delivered out here, there's again no strict protocol. My threshold is 2 to 3 double sequential external shocks in someone that's a good candidate for ECMO. That's a person that should be transported to the hospital with CPR in progress for ECMO cannulation, or alternatively, depending on your system, like ours or a few others where we do pre-hospital activation, we would go out and do the field cannulation for ECMO. Generally speaking, again, those patients in our system are already classified in just the way our dispatch works. Even again, systems of care are very important. We're getting dispatched simultaneously for ECMO activation on a lot of these patients who are already getting dual external defibrillated. And so again, that's sort of systems of care stuff. So if you're not in a system like that, which I would argue is actually a lot of systems that do not have pre-hospital or easy access ED ECMO, then I would say your shock refractory patient, I generally argue for about 20 to 30 minutes of additional CPR if they're in persistent refractory VF. And I am generally terminating resuscitation once we hit the 40-minute mark, 45-minute mark. If the pupils are fixed and dilated, they could still be in VF, and if the end tidal is generally below 30. I have pronounced people with end titles in the 70s with persistent refractory VF for 40, 45 minutes. Again, reminder that end tidal is just a surrogate for perfusion, how well you're doing CPR, not necessarily if the patient is viable or not. And also just looking at the other clinical contexts of things. How old is the patient? What was the patient's pre-cardiac arrest sort of quality of life? Was this someone that was like, walkie-talkie around and was able to do all their ADLs, IADLs on their own? Or
not a 98-year-old quadruple amputee.
Right. Yeah. So I think, those are sort of my thresholds for pronouncing somebody in persistent VF. Again, I would say I would probably bet that for those who are listening here that are advanced life support providers, if you have a patient in refractory VF, I would bet money that you have to talk to medical command before you pronounce that patient. That generally seems to be the national trend, at least within the US and Canada, that I've seen from other medical directors I've talked to, that you generally for VF rhythms or VT rhythms, you have to talk to medical command before you make that field termination, as opposed to PEA or asystole.
That seems reasonable.
Yeah, I think that's right. And I think that's probably in line with most of the standard protocols and, most guidelines that seem to be out there. But this is yeah, go ahead, Mike.
The one last thing I wanted to talk about real quick before we end out is just because this is a common trope I hear whenever I talk about this, not so much among EMS providers. I feel like EMS clinicians are very about this, but other ER docs and intensivists I talk to is that, what if this is going to destroy the manufacturer warranty and destroy the DFib? That was the third paper we looked at, which was a review nationally among US EMS medical directors about whether there was any significant damage. There was, out of 1,100 cases of dual sequential external defibrillation, there were only 5 cases, 4%, where there was defibrillator damage. And just to put that in perspective, those were cardiac arrest cases. We're talking between 2,000 to 4,500 double sequential external defibrillations, individual defibrillations. There was a rate of defibrillator damage between 0.1 to 0.2% of the time. And I think when you're looking at, benefit of the public to having potential ROSC with neurointact outcome versus the small risk of destroying a defibrillator, again, my personal opinion that it's worthwhile to do this.
And again, I think that's right. And that's where it starts getting into the more, grotesque conversation of money over, over healthcare. Yeah, and I would venture to say, and again, not to be too glib about it, most EMS systems, most hospital systems have at least one backup monitor. So that's kind of my view on that. But Dr. Mike DiFilippo, our medical director, this was published on yesterday, so January 21st as we're recording this. It's out of Air Medical Journal. The link will be down in the show notes. Be sure to follow us on YouTube, Spotify, Apple Podcasts, wherever you get your podcasts. Check us out on TikTok because we're back on there now that ban is over, and on the rest of social media. For the Overrun podcast, my name is Ed Bowder.
I'm Dan Schwester.
And we will see you all next time. Thanks for listening. We'll talk next time.